Good evening. Ask Me Anything with Dr. Twyman starts now. So I hope you guys are getting ready for your holidays. Got a couple more days at Apollo and then kind of shut down for the year. So tonight we will answer your questions and start with the first one. So, what is the prognosis for somebody whose left main artery is 60% blocked? This is a significant issue. That is a high risk for sudden cardiac death. Patients who have left main disease greater than 40% are generally offered coronary artery bypass grafting surgery or high-risk PCI, stenting of the left main artery. So you should be talking to your cardiologist about revascularization if you have a significant left main stenosis. I think this was a continuation of that previous one, and the person's only 45 years old. So I would be concerned that you have LPLA, potentially 9p21, the heart attack gene, KIF6, or APOE4 alleles. These are the four main genes that we check in every one of our patients. And in polycardiology, if there's also a strong family history, we'll often look at other markers depending on other risk factors. But if you have severe coronary disease at 45, there's likely a highly genetic predisposition to that. So you got to figure out what's causing the endothelial dysfunction, cool down the inflammatory cascade, and aggressively treat the lipoproteins. And if that was my patient that I was taking care of, I would be shooting for an ApoB less than 55 in that individual. Next question up tonight. High cholesterol, triglycerides in the 3,000, and plaque in the arteries. How to get back to healthy. So if you have a triglyceride of over 3,000, that is a medical emergency. The risk of pancreatitis is high. Pancreatitis can be fatal as the triglycerides damage the pancreatic tissue. Triglycerides over 3,000, if it's not due to alcohol, it's generally going to be due to some issue with lipoprotein lipase, and you need aggressive medical therapy. Fibrate therapy, potentially high dose omega-3s, 4 grams or higher, to treat the triglycerides. Once triglycerides are treated, then you go back and treat the cholesterol metrics, but I would look at the LDL particles and ApoB and treat those. How to get back to healthy? Got to figure out what's driving the high triglycerides. If it's insulin resistance in part, treat that, but that's going to take a significant workup. It's not just going to be just lifestyle interventions. Next question, is plaque in the LAD worse than having it somewhere else? So the left anterior descending artery is the artery that goes down the front part of the left ventricle, provides approximately 70% of the oxygenation and blood flow to the myocardium. I don't like the term, but this artery is known as the widowmaker. Any artery that has a plaque rupture can be fatal, but because this artery supplies the majority of blood flow, it's not great to have a significant plaque in the LAD. In the old days before they had stents, this equaled bypass surgery if you had a severe disease just in your left anterior descending. Now with the advent of modern stents, LAD stenting is routine practice, so not as bad as was in the past, or definitely not as bad as the person previously in the questions asking about a 60% left main lesion. That is the worst place to have it, because that would also take down the circumflex of that artery occludes. How would I treat white coat hypertension? So white coat hypertension is diagnosed as high blood pressure in the office and normal blood pressure at home. To diagnose it, you have to use a 24-hour ambulatory blood pressure monitor. And if you are lucky enough to get that Helo device from Europe, you can somewhat assess if you have white coat hypertension at home. But it's essentially a stress-induced hypertension with high sympathetic drive, so high catecholamines, adrenaline, constricting the arteries. You can monitor heart rate variability and do techniques to monitor if heart rate variability is getting better. Those things can be biofeedback, neurofeedback, meditation, deep breathing exercises. Anything that activates the vagus nerve will potentially improve this. This may be also where you get into the wearables like the Apollo Neuro, the Pulsetto. There's many various companies developing these vagal nerve stimulators. That's how I would initially go about treating white coat hypertension. But the goal is to have a blood pressure of 120/80. because even if your blood pressure is high due to stress, the arteries don't know the difference with that, and the shear stress can damage the glycocalyx and the underlying endothelium. So somebody's asking if I'm doing well. Yep, doing well. Getting ready for the holidays. What are my thoughts on the new LPA and waist study? Don't know exactly which study you're speaking of. I don't know if this is the oral LPA or not, a lowering agent, but maybe if you're on this call, just drop it in the comments, and I'll let you know if I know which particular study you're speaking of. So somebody says, will Elon come out with a shot which allows you to dodge a heart attack? The short answer is probably not. It's not going to be one thing that reduces the risk of a heart attack. It's multiple. There's over 400 things that contribute to plaque in the arteries. So that's why I don't focus on just lowering lipoproteins. I usually break it down into 3 big buckets, and then there's going to be some side buckets you'll look at depending on the patient's risk factors and their family history. But number 1, is it affecting the nitric oxide pathways? So a gentleman today had 2 genes that affected NOS3, so had very low nitric oxide because of that. Inflammation, you can look at Boston Heart Labs, Cleveland Heart Labs, Quest, LabCorp, many companies will do these testing. But if you have a lot of oxidative stress and inflammation in your blood, your arteries are more likely getting damaged. And yes, there are multiple drugs that can treat lipoproteins. Don't think Elon's involved in any of those particular ones. So somebody says that their dad had survived a heart attack at the age of 55. The primary doctor didn't prescribe blood thinners. So I don't know if he meant to your father or to you, but if a person had a heart attack, it can be where it's just medically managed. Then generally you're going to treat with aspirin and likely clopidogrel. If the person had a heart attack and got treated with a stent, then generally it's definitely going to be doing antiplatelet therapy for a minimum of 3 months, more likely 12 months. And if the person had bypass surgery, then typically you just use aspirin alone. Now, if you are asking for yourself, if you have a family history, then you got to look at your bleeding risk, particularly peptic ulcer disease. If your risk of bleeding is high, then definitely shouldn't be taking aspirin as primary prevention. But if your risk is low, talk to your doctors about the benefits of adding low-dose aspirin, 81 milligrams daily. And you generally take it in the evening time because your blood is more sticky overnight as cortisol is starting to increase. I think we got through all the pre-submitted questions. If anybody has a question they want to drop in the comments, I'll answer that for you. And while waiting for those questions to roll in, as always, I appreciate your guys' time and attention. These questions are great because this helps the whole community learn. I answer these type of questions every day at Apollo Cardiology, where my practice is in St. Louis, Missouri. I have patients coming from all over the country. Today we have somebody locally from St. Louis, but also somebody from New York. If you're ever in my office, you'll see the map on the wall with the pins in it. That is a map of where all our patients are from this year who traveled in to come see us and get their vascular risk assessed. So I'm very grateful to all the patients that travel to come see me and take their time, effort to make it to St. Louis for my team to do our evaluation for them. If you're ever interested in a one-on-one consultation with me, go to my website, drtom.com, and apply, and my team will discuss it with you. Right now, I'm booking out pretty far in the future, at least 3 to 4 months, so don't wait too long if you really want to work with us. All right. So is slow-release aspirin better than regular? Not generally. Aspirin sometimes will have a coating on it, the buffered, just in case somebody has some gastric irritation from the pill in the stomach, but the bleeding risk is the same because once the aspirin is dissolved, it doesn't matter. It's going to potentially still increase peptic ulcer disease or bleeding through the GI system, so not necessarily better. And then, is it better to take once a day medication in the morning or night? There's chronobiology or circadian biology of all medications. Some are better in the morning, some are better in the evening. Majority of blood pressure medications are better taken in the evening time, but that's confirmed with a blood pressure 24-hour monitor. Most lipid-lowering therapies now are long enough acting, it doesn't matter morning or night. Some of the older statins generally had to be taken at night because the enzymes that affected lipoprotein development were more active at night, so you would take your medicines at night for that one. But basically, it doesn't matter for most medicines, but many of the cardiac medicines are generally better in the evening time. Somebody says that their newest blood test showed an LPA of 905. That would be very elevated, even if it's nanomoles per milliliter instead of the nanograms per deciliter testing. What can you do? Many things. What is the ApoB? And start targeting that. The ApoB is going to be on the outside of that LPA as well as your LDL particles. You're going to want to likely shoot for an LDL particle number less than 1,000. For LPA, I will often check LP-Play2 activity, which is an inflammatory marker. OX-PLA ApoB, if you oxidize your phospholipids, that's the cargo that LPA is carrying around in your arteries. And then look at interleukin 6 or IL-6. If IL-6 is high, your arteries are inflamed. Those three labs tend to mean that LPA is damaging the arteries. How to lower it? There are not great effective treatments that significantly lower LPA, so you got to treat all of the risk factors to keep inflammation low. Support the glycocalyx so the LPA doesn't stick to the arteries. But to lower it, apheresis, mostly done at academic centers. They take the blood out, spin it down, take out the LPA, put your blood back in, but that's only a temporary solution. You usually got to go back every 2 to 3 weeks then. Not that common in the United States, but that is the best treatment at lowering LPA. Until the antisense oligonucleotides and the small interfering RNA molecules come out, it's really going to be the PCSK9 inhibitors that may have about a 20 to 30% reduction in LPA. All right, so next person says that they were diagnosed with a TIA, which is a transischemic attack. It's essentially a mini stroke, or it's a precursor to a full stroke. All labs, which depends what the labs are. CT, depends what type of CT, MRI, and echo normal. So labs would have to look at all the inflammatory and oxidative stress markers, potentially look at some of the clotting cascades, factor C, factor S, factor 2, factor 5 Leiden. CT, would be CT angio, looking for atherosclerosis in the carotid arteries, look for small vessel disease in the brain. Same with MRI. It's typically not done with contrast, but can look for, is it in multiple territories or one territory, or if there's no brain injury. Usually it shouldn't be with TIA, but you can see evidence of old white matter changes, which can be old strokes. And echo is looking for emboli or clots on the valves or a clot inside the left ventricle. But they often will do an IV saline injection to look for a shunt between the right atrium and the left atrium. That's typically due to patent foraminovaly or PFO. There's rare occasions where it's due to atrial septal defect. But if all those tests are coming back, quote, really normal, then you got to rule out atrial fibrillation. Usually you have to wear a 7 to 14 to maybe 30-day monitor to evaluate that if there's any arrhythmias that could increase the risk of clot. And then do more advanced testing with lab work to figure out if there's anything that is predisposing the blood to be more likely to clot. Any tips for anxiety-provoking tinnitus? Tinnitus is not my area of expertise. Generally recommend that people get a hearing study with a kind of a certified audiologist to figure out is it an actual truly hearing loss issue. May need a workup by otolaryngology. But the anxiety, can increase the Y-code hypertension. The stress hormones constrict the arteries, raising the heart rate. So favorite thing for that is generally going to be meditation or biofeedback with a device called HeartMath. If people are into more of the wearables, then the Apollo Neuro device can help with some healing touch. And there are various vagal nerve stimulators that can help with anxiety as well. How do statins affect the mitochondrial function? It depends on which statin, it depends on what dose, but it affects cytochrome C oxidase. All right, I'm not seeing any other questions coming in at the moment. So I hope you guys have a Merry Christmas, Happy Holidays. I will come back on here next Monday, 6 p.m. Central Time, answer more questions for you. And then I'll be taking a kind of a winter break for a couple weeks, and I'll be back after that. But if you're looking for more content like this, my school community is where I'm putting, almost daily content at this point. Still putting some of my notes in from when I went to the A4M Longevity Conference the other week in Las Vegas. So I attended some great conferences on brain health and, basically markers of inflammation in the brain. So if you're interested in that type of content, it's on my school community, which is school.com/Dr. Twyman, or reverse, drtwyman.com/school. I bought the domain to both. And that's where I'll also be doing longer form Ask Me Anythings. I do at least one of those per month. The next scheduled one is January 2nd at 7 a.m. It's kind of a coffee and cardiology. So people bring their questions, bring their labs, and I help answer the questions for them. If you're looking for more kind of back and forth kind of response to your questions, that's an easier place to do that. I put up a few AI summaries that I've done for different articles I've read. I've had ones that have summarized 30 of my top podcasts. So if you don't have 30 hours to listen to all my content, there's a 6-minute summary of all those 30 podcasts that tells you the basics on how to keep your arteries healthy and try to become heart attack proof. So hope you guys have a great night, and I'll see you next Monday, 6 p.m. Central Time.